Eric Michelson is back, this time with Dr. Ronald Victor, Professor of Medicine and Director of the Hypertension Center of Excellence at the Mount Sinai Medical Center in Los Angeles, California, to discuss hypertension in ethnic minorities.
Ron, welcome.
Thanks, Eric.
Could you give us your perspective on this as an expert?
Well, I talked mainly about hypertension in African Americans. I think most cardiologists know that African Americans suffer disproportionately from hypertension. The disease is not only more prevalent in African Americans, affecting about 40% of the adult population. It also starts at a younger age, is more difficult to treat, and causes excessive and premature disability and death. Heart attack, stroke, kidney failure, and heart failure.
Is this a environmental, cultural issue predominantly, or genetic, or mixed?
It's been a big debate. Hypertension's been one of the most difficult nuts to crack when it comes to genetics of common cardiovascular disease. And what strikes me is the geographic variation in prevalence of hypertension among the African diaspora. So Richard Cooper did a very nice study several years ago where he showed that hypertension is infrequent in many African populations. It's intermediate in people of African descent living in the islands, and it's high in the United States. But it's a myth to say that African Americans have the highest prevalence of hypertension in the world, because as high as the prevalence is here, hypertension is still more common in Northern Europe, people of European descent, than it is in African Americans. So that striking geographic variation to me speaks to the importance of environmental factors.
Well, that's a remarkable, enlightening piece of information. It also then suggests opportunities for intervention that might not otherwise be available to us.
Absolutely. Lifestyle intervention for hypertension has been around for a long time. It's easy to talk about, hard to enact in our busy daily lives. To play devil's advocate, individual behavior therapy for lifestyle changes is a bit of the emperor with no clothes. It works better at the societal level. This is something I think that we need to take very seriously as a society. So, for example, smoking cessation, by enacting laws that make it very difficult for folks to smoke in public, is about the only way to combat the tobacco industry. The same token, there's been a really dramatic study from our colleagues at UCSF led by Kirsten Bibens-Domingo. And she said, well, our salt consumption in this country, our kidneys were meant to handle about 5 grams of sodium chloride a day. And the average American eats about 10 grams of sodium chloride per day. And most of this doesn't come from the salt shaker, of course. It comes from processed food. So if we can only get the food industry to reduce the salt content of processed foods from consumption of about 10 grams per day to 7, just a 3-gram change over a decade, that'd be so small that no one would know the difference in the way the food tastes. We could save countless heart attacks and strokes just by driving down the population's blood pressure by a couple of millimeters of mercury. And the group that would benefit the most would be African Americans.
Is the problem in part early detection? Is it detection and intervention? Where are, if you will, the rate-limiting steps that we can begin to intervene, in addition to these societal changes about less salt in the soup?
Our work has suggested that there are big gender differences when it comes to how to improve hypertension control in African American men and African American women. So African American women have very high rates of hypertension awareness and treatment, but low rates of control, and the issue seems to be at the doctor-patient interaction level. In African American men, the rates of awareness, treatment, and control are far less than in women. And the main issue is that men are much less likely to see a physician frequently for preventative care than our female counterparts. And that's the reason for lower rates of awareness, treatment, and control of hypertension among African American men. And so we went outside the traditional halls of medicine to find men who need to get their blood pressure treated and controlled. And so we enlisted the aid of African American barbers.
Right, the so-called barbershop study.
Yes, the famous barbershop study. So at this point, I need to declare a potential conflict of interest. Eric's mother, Ellen Spector, ran the field staff operations to evaluate our program through Temple University Institute for Survey Research. So now I have given complete and full disclosure.
I appreciate that. So will my mother.
Well, she did a fantastic job. So we had a group randomized trial of 17 African-American-owned barbershops, all in Dallas County, Texas, where I used to work. Those shops went through a very detailed screening process through your mother's field staff. So these shops were staffed at all business hours for 10 weeks by African-American field staff. All the adult male customers were screened twice to detect hypertension. And then the barbershops were randomized to a control group that received American Heart Association pamphlets on hypertension in blacks. And the active intervention group didn't receive any pamphlets, but for 10 months, they received continuous blood pressure checks by the barbers. All the male customers did. And then when men had elevated readings, the barbers then referred them to our field staff, who would triage the men into appropriate care depending on their health insurance plans or lack thereof. The idea is that barbershops are very popular places that black men go to frequently for haircuts and enjoy long-term relationships and close relationships with their barbers. Since the Middle Ages, barbers could pull teeth and put on leeches and do bloodletting, do minor surgery. They could certainly learn to use electronic blood pressure cuffs, and they were the real heroes of this study. They did a fabulous job.
And this is real community-based care.
It is indeed.
So what were the results?
The evaluation was 2 surveys. There was a data collection pre-test and then a same data collection post-test. It was a series of health questionnaires, one-on-one interviews, as well as multiple measurements in blood pressure on 2 different days to get accurate readings of blood pressure. So at the end of the day, we had positive results. We declared victory because p-value was 0.03, and there was a blood pressure fell in both the intervention group and the control group, but it fell more in the intervention group by an additional 3 milliliters of mercury systolic. And if that were applied to 50% of all African-American men who are loyal barbershop clients around the country, something like 18,000 African-American-owned barbershops, that we would prevent very large numbers of heart attacks and strokes and heart failure hospitalizations in the first year alone. And if the results could be sustained, we would have serious impact on cardiovascular health. We'd like to have a bigger impact and have a more cost-effective program. Went back and looked at the data to see if we understood the results. Every barber didn't fully embrace the programs, but in general, the barbers did a great job. They could deliver intervention messages that resonated with their clientele, who, by the way, were average patrons for about a decade, that same barbershop, and come every 2 to 4 weeks to get their hair cut. And every man didn't listen to his barber and follow up with a physician, but over 60% did. And the reason we didn't have a stronger result is that the doctors in the community undertreated the hypertension these men had. So on average, the doctors prescribed either no medicine or on average about a half a pill in addition to what they were taking at the beginning. Whereas, hypertension is a multifactorial disease and requires treatment. By the time we record a 140 over 90 or higher in the office, most patients need 3 different medications to control their hypertension.
Yes, and had the same patients been afforded the advantage of effective treatment earlier, data do show probably that much less medicine might be effective for a much longer period of time. Is that correct?
You're talking about the famous trophy trial in part?
Among others.
Yes. So if we could start hypertension treatment in youth, probably take a touch of medicine, in high-risk hypertensives to slow that age-dependent rise in blood pressure that we all seem to have. So it might take just a touch of medicine to do that, especially if we can enact these societal-wide lifestyle modifications.
So at the end of the day, if we're looking again, our topic, hypertension in ethnic minorities, it seems like the approach might be similar regardless of an ethnicity, but you're saying if in part the African-American black population in the United States has so many of these other factors, environmental, culture, diet, weight, that we need to really be very, very aggressive and, if you will, almost religious about attention to these multifacets, including getting to them early and imprinting on them the critical importance of maintenance of blood pressure in reasonable ranges?
Yeah, so...
And the physicians?
Hypertension is the number one reason that African American men have expected lifespan of only 69 years, which is almost a decade less than white men in this country and lower than in many third world countries. It's a very serious issue. And so the International Society of Hypertension in Blacks, the ISHB organization, has just issued a new guidelines recommendation in 2010 that there ought to be a stretch goal lower than usual blood pressure goals for just the reason that you're suggesting. So that rather than an office blood pressure of 140/90, the goal for most African American persons ought to be below 135/85. And if there are additional cardiovascular risk factors, then it ought to be below 130/80. There was an editorial written in the journal Hypertension right after that saying that the clinical trials don't really provide evidence to support that, and this is really expert opinion. So in my expert opinion, a lower than usual stretch goal might be one approach to offset physician inertia in treating hypertension. The key message I'd like to leave is that low-dose combination therapy is where it's at to treat hypertension. It usually takes 3 medicines. The 3 first-line drugs now on almost everybody's guidelines are a dihydropyridine. Amlodipine is now generic, and it's long-acting and performed very well on the trial. So amlodipine for sure, a RAS blocker, and a low-dose thiazide are the 3. I usually start patients on 2 of those 3. I like amlodipine plus a RAS blocker, and for African-American patients, I shy away from ACE inhibitors because there really is a 3 times higher risk of ACE cough and ACE angioedema. So I like to use ARBs for African-American hypertensives. Thiazides are to be the lowest dose required because of all the different drugs, thiazides are the ones most commonly associated with erectile dysfunction. And so for male patients, that's a real issue. And then if someone has a family history of diabetes or is overweight, he may have impaired fasting glucose. Again, I shy away from the thiazides because they really can increase the risk of new onset diabetes.
And particularly for cardiologists, the patients are already going to be on multiple medications.
Yeah.
But regardless of that, it seems that we do need to be aggressive. We're accustomed already in diabetics to pushing blood pressure to lower targets, obesity, diabetes, hypertension, often together.
And it's important not to delay getting started with antihypertensive therapy. I think a lot of times the patient says, Doc, I showed up at the appointment, I had to get through traffic to get here, maybe my spouse fussed at me, I had a bad day at work. You can make a lot of excuses, and the white coat reaction can overestimate blood pressure. I think it's very important to use out-of-office monitoring. In our case, it was in a barbershop, but home monitoring is good. Also, I think very important if someone's blood pressure is 135/85 or higher outside the office, it's time to start antihypertensive therapy and not delay. As we talked about earlier, an ounce of prevention is worth a pound of cure. So low dose of a blood pressure medication in a young patient could be very important for controlling the blood pressure over the lifespan and reduce that total burden. Like you said, pack years of tobacco, but it's pack years of extra millimeters of mercury.
Yes.
The hemodynamic burden on the left ventricle and other target organs are to be reduced as soon as possible.
Okay, Ron, thanks for sharing your expertise, and thanks particularly for your interest in aggressively treating hypertension in everyone, particularly ethnic minorities.
Thanks, Eric. This is a pleasure.